Welcome to the Depth Dive. Today we are cracking open Porth's Pathophysiology, Chapter 39, Alterations in Nutritional Status. Our mission is really to cut through the density here and get to the heart of the body's complex energy system. You know, what we eat, how we store it, how we burn it, and critically, what happens when that whole system, well, fundamentally breaks down.
Exactly. We're looking beyond just, counting calories. We're digging to the actual physiological machinery, the critical mechanisms behind obesity, the really devastating effects of malnutrition, and getting those precise definitions right so you understand the clinical picture. We want you to walk away with a clear structural view of this material.
Okay, so let's start right at the beginning.
Yeah.
Energy. When we talk fuel, we mean kilocalories, right? Or the large calorie with a capital C. Why do we need to, really drill down into the specific calories from different macros?
Well, it's all about energy density. It dictates how the body stores and uses fuel. It's quite specific, actually. When these are oxidized, protein and carbs both give you about 4 kilocal per gram. Fats, though, they're much more efficient storage, 9 kilocal per gram. And the one people often forget in calculations, alcohol, that's 7 kilocal per gram. These numbers are, well, fundamental to understanding metabolic balance.
Okay, so that's the input. But how does the body manage the flow? Storing versus using. What are those two sort of opposing processes that define that constant energy transaction?
Right, that's anabolism and catabolism. Anabolism is the building up phase. It's synthesis and storage, so it actually requires energy. Think building glycogen or fat. Catabolism is the opposite, breaking down complex molecules for energy. That releases ATP, which is, the cell's energy currency.
Okay, now here's where it gets really interesting, I think. Challenging that old idea that fat is just inert storage. Porth points out adipose tissue is actually this highly complex endocrine organ. What's it secreting? Why does that change things?
It absolutely changes things. It's a major metabolic player. Yes, it holds over 90% of stored energy as triglycerides and white fat. That's huge. But it's actively secreting factors called adipokines. And the really critical one is leptin. Leptin is like the body's long-term energy sensor. It tells the hypothalamus, the brain's control center, hey, we've got enough calories stored. That should then decrease food intake and ramp up energy expenditure through thermogenesis.
So leptin is meant to be the brake signal. We're full, stop eating. But in many cases of obesity, the body's making tons of leptin, but the signal fails. That's leptin resistant.
Precisely. The communication line is broken. Even if the energy tank is overflowing, the message just isn't getting received properly by the brain.
Yeah, that failure really highlights how complex this energy economy is.
Okay, so even if storage signaling is messed up, the body's still burning energy constantly. Let's talk expenditure. How do we measure that energy the body burns just existing? That's the Basal Metabolic Rate, or BMR. You might also hear it called resting energy equivalent, REE. It's the absolute minimum energy needed for vital functions, breathing, heartbeat, keeping warm. And it accounts for a huge chunk of your daily energy needs, maybe 50 to 70%. Interestingly, variations in BMR are largely down to differences in skeletal muscle mass. Muscle is metabolically expensive stuff to maintain.
And then there's that other type of burning energy, the subtler one. But Porth emphasizes it's actually pretty important. NEAT.
Yes, NEAT. Non-exercise activity thermogenesis. It sounds fancy, but it's basically all the energy you use for everything that isn't structured exercise. Things like standing up, maintaining your posture, walking to the printer, even fidgeting. And what's compelling is some data suggests lower NEAT levels might correlate with a tendency towards weight gain. It shows just how much that spontaneous daily activity matters.
Okay, so all these systems are feeding info to the brain. But how does that translate into actually feeling like eating? We need to be clear on the terms here. Hunger, appetite, satiety. What's the difference?
Good point. Hunger is that physical, visceral feeling, stomach pangs, feeling empty. Appetite is more psychological, the desire for a specific food. You might not be truly hungry, but you have an appetite for chocolate, right? And satiety is the feeling of fullness after eating, the signal that decreases the desire to eat more.
And these feelings are driven, short-term at least, by this neurohormonal chatter. What's the main hormone yelling, eat now?
The primary or exogenic signal, meaning feeding increasing, is ghrelin. It's mostly made in the stomach. Stomach's empty, ghrelin levels rise, tells the brain time for food. On the flip side, lots of gut hormones released during digestion act as anorexigenic signals, telling the brain, okay, we're good for now, promoting that short-term satiety.
And beyond ghrelin and leptin, there are other long-term signals too. Porth mentions keto acids having an effect.
Yes, that's relevant, especially with things like ketogenic diets. Keto acids are breakdown products when the body is heavily metabolizing fat. Their presence seems to act as another signal of nutrient availability, reinforcing satiety in the brain. It ties metabolism directly to appetite control.
Right. Okay, let's pivot now. Let's talk about the first major imbalance, overnutrition leading to overweight and obesity. Clinically, we start with BMI, body mass index.
Yep, BMI. It's just a calculation, height and weight. For adults, 25 or more is overweight, 30 or more is obesity. Simple enough. But for kids, it's different, based on growth charts hitting the 95th percentile for age and sex. BMI is just the first screen, though.
Yeah, because the crucial thing from this chapter, I think, is where the fat is. That's the whole apple versus pear shape idea.
Yeah. Exactly. That's visually shown in figure 39-4 in the book, and it's vital. You have upper body or central obesity, that's the apple. Fat stored mainly in the abdomen, around the organs, the viscera. Then lower body or peripheral obesity, the pear. Fat is more around the hips and thighs.
And why is that belly fat, the apple shape, so much riskier?
It's because that visceral fat is metabolically very active, and it's right next door to vital organs. It dumps adipokines and fatty acids straight into the portal vein, which goes directly to the liver. And that directly fuels insulin resistance, fatty liver disease, and systemic inflammation. It's a major driver of metabolic problems. The risk is considered high if the waist-to-hip ratio is over 1.0 in men or over 0.8 in women.
So measuring waist circumference actually tells you more about that specific visceral fat risk than BMI alone, even if someone's just overweight by BMI. And the health consequences of central obesity are huge. Type 2 diabetes, heart disease, sleep apnea, even certain cancers.
They really are. And treatment-wise, look, lifestyle change, diet, activity, behavior, that's always the foundation. But for clinically severe obesity, the evidence is pretty strong. For a BMI over 40 or over 35 with serious health problems tied to the weight, bariatric surgery currently offers the most effective long-term results for significant, sustained weight loss.
Okay, let's shift gears completely now to the other end of the spectrum, undernutrition and starvation. This isn't just a developing world issue, although it's huge there. It affects specific groups everywhere, sick patients, older adults, kids. And in children, Porth really stresses differentiating the two main types of protein-energy malnutrition, PEM.
Yes, this is absolutely crucial to get straight. First, there's marasmus. Marasmus is severe deficiency in both calories and protein, total lack of intake. The child looks wasted, severe loss of muscle, loss of fat, leads to stunted growth, skin looks wrinkled because the fat padding is gone. It's total energy depletion.
Got it. Wasted appearance, marasmus. And the other one, kwashiorkor.
Kwashiorkor. This one's different. It's primarily a deficiency in protein, even if some calories are coming in. Often happens when a child is weaned onto, say, a starchy, low-protein gruel. They get calories, but not the essential building blocks. The big issue here is the body can't make visceral proteins anymore, especially albumin.
Ah, okay. So if marasmus is the wasted look from total lack of fuel, kwashiorkor is the swollen look because of the protein deficiency leading to edema.
Exactly. That lack of albumin, the hypoalbuminemia, means fluid leaks out of the blood vessels into the tissues, causing generalized edema. That's the defining feature. You also see those classic signs described: the flaky paint, skin lesions, and changes in hair pigment, the flag sign. That visual is key.
Makes sense. And the overall effects of severe malnutrition, regardless of type, they're system-wide, right?
Absolutely devastating. You see major loss of muscle mass, and that includes respiratory muscles, making breathing difficult. Wound healing is impaired. The liver can't synthesize serum proteins properly, and the immune system is severely depressed. So much so, these patients often can't even generate a fever when they get an infection, which is a really bad sign.
Wow. And diagnosing these states, Porth says no single test is perfect, but labs are used. Which protein markers are key?
We often look at albumin and prealbumin. Albumin reflects longer-term status because it has a long half-life, maybe 20 days. Prealbumin has a much shorter half-life, just a couple of days, so it's actually more sensitive for picking up acute changes in nutritional status, recent dietary intake.
Okay, good distinction. Finally, let's just touch on those specific conditions resulting from self-imposed dietary restriction, eating disorders. The chapter notes binge eating disorder, BED, is the most common, but we need to compare the two sort of classic restrictive ones.
Right. First, Anorexia Nervosa, ANN. This is defined by a refusal to maintain even a minimally normal body weight. The book gives a specific threshold, BMI less than 17.5. Plus, there's this intense fear of gaining weight, a severely distorted body image, and usually amenorrhea, loss of periods in women.
And the physical complications sound brutal, really reflecting that starvation state.
They are. Osteoporosis is a big one, due to low estrogen. Serious cardiac problems, slow heart rate, decreased heart size, even loss of brain tissue, both white and gray matter. The cardiac risks are a major concern in severe AN.
Okay, contrast that with bulimia nervosa, BN.
Right. BN is characterized by recurrent episodes of binge eating, consuming large amounts of food, followed by compensatory behaviors to prevent weight gain. That could be self-induced vomiting, abusing laxatives or diuretics, fasting, or excessive exercise. But the key clinical difference from AN, most people with BN are actually of normal weight or maybe slightly overweight. They aren't typically emaciated.
Okay. And the complications of bulimia are more related to the purging methods themselves.
Largely, yes. That's where you see the telltale signs. Frequent vomiting causes dental erosion from stomach acid. You can get swollen salivary glands, peritonitis, and metabolically, you often see alkalosis and dangerously low potassium levels, hypokalemia, from losing fluids and electrolytes.
Okay, that clarifies the distinction. So let's try and wrap this up. What are the absolute must-know takeaways from this deep dive?
Okay, three big ones. First, really internalize that adipose tissue isn't just passive storage, it's an endocrine organ, with leptin as that key long-term energy signal to the brain. Second, for obesity, remember location. Apple-shaped, that central visceral fat, is far riskier metabolically than the pear-shaped peripheral fat. Waist circumference beats BMI for assessing that specific risk.
Got it. Adipose is endocrine, apples are riskier than pears, and the third,
Don't confuse marasmus and kwashiorkor in kids. Marasmus equals total wasting from lack of everything. Kwashiorkor equals edema from lack of protein leading to low albumin. Remember the swelling.
perfect summary.
Now, thinking about all this, the genetics, the ghrelin, the leptin, the hypothalamus are trying to manage BMR and a potential weight set point. Here's something to chew on. Given how many internal factors regulate our energy balance, how much conscious control do we really have over our weight? And thinking bigger, how should that complex reality maybe reshape our public health strategies for tackling obesity?
That definitely complicates the simple eat less, move more message, doesn't it? A really important question to ponder. Okay, a huge thank you for joining us on the deep dive today. We really appreciate you trusting us with your valuable time and attention. If you're looking for more in-depth content like this, do check out the blog summaries and other resources available from the Last Minute Lecture team. We hope to catch you on the next deep dive.